Thank you for your attention, dear colleagues, Orazio, Johan. And I want to present our experience with the ROS operation in children and to try to transfer our experience after almost 20 years of experience, because I started with the ROS operation in August 1994, and now it's more than 19 years, and we learned something. So I want to transfer our experience and our suggestions for ROS operation. Sorry. Okay, the first time in 1967, Dr. Ross successfully replaced the aortic valve with a pulmonary autograft. This is a ROS operation. In order to understand, for the people who are not used to work and to be confident with the ROS operation, the ROS, from surgical point of view, can be done in 3 ways: aortic root replacement, subcoronary implantation, and occlusion technique. But what is the ROS operation? I prepared the animation in order to show to you. Just a moment. Okay. Which is the ROS operation? The ROS is a very complex operation from technical point of view. You have first to harvest the pulmonary artery trunk with the valves from the outflow tract of the right ventricle. After that, you remove the aortic root. You remove the valve and you change the aortic root with the pulmonary root, which becomes the new aortic root. After that, you do the reimplantation of the coronary arteries. So the new aorta now is constituted by the pulmonary trunk and the remnant part of distal aorta. After that, the last step is to reconstruct the right outflow tract with the conduit, but the best product is a homograft. The best results are there. Okay, this is a ROS operation. When we have to do the ROS operation, we'll see. Which are the advantages of a ROS operation? It's natural autologous valve with 3 cusps, viable tissue because it's pulmonary artery. It's a growth potential, and we demonstrate it presents excellent hemodynamics and duration, low risk of endocarditis, no thrombogenicity, no need for anticoagulants, and allowed the pregnancy and the sport activity to the young people. But also, the ROS operation presents some potential late complications, like aortic valve regurgitation. The pulmonary valve is not aortic valve, and sometimes it cannot afford the systemic pressure. So we can have some valve regurgitation in the future. Or we can have a progressive neo-aortic root dilation, or pulmonary homograft, or substitutes deterioration. So I want to present some of these complications. This one is an example of neo-aortic valve degeneration after 10 years. This is the aortic cusp with a big hole inside. This is the cusp, completely degenerated, as you can see here, with the hole and destruction of all the cusp. The results, very severe aortic regurgitation, and we have to redo the operation after 10 years. But this is one complications. The other one is autograft dilation post-ROS operation. And we have seen that the dilation can occur in 10% of the cases after 10 years. So we have also to take in consideration this possibility in order to select the patients and give the indications. In order to try to avoid this kind of complication, we apply the method of Gore-Tex membrane harvesting covering the neo-aortic or pulmonary aortic route with a Gore-Tex membrane. We did in 20 cases from July 2003 to September 2006. After that, we stopped, not because the results were not good, but because we want to know the long-term results when we do something. We want to know if what we are doing is good or not. So we are waiting for 10 years, and this year we start to evaluate all the cases. Up to now, we have only one aortic regurgitation due a prolapse, not due to dilation. So probably this technique is a good one, and we have to restart with that. But which are the most common causes of failure for pulmonary autograft? It means for new aorta. Technical errors during dissection and the implantation of pulmonary autograft, late endocarditis immunologically mediated injury, or structural changes in the autograft that predispose to dilation of the autograft. As I told you, the pulmonary artery is not aortic. And this is an example. 12 years after operation, the new aorta, it means the old pulmonary artery, presented the focal interruption of the elastin skeleton of the media. So in these cases, we had an aortic dilation due to this mechanism. So you have to know that there is also this possibility. For that reason, we have to select the patient. But first of all, you have to have a good results, because a Ross operation means that you have to change the aortic valve. If for changing the aortic valve you have high mortality, it's better to do simple operation like aortic valve replacement. For that reason, we are just evaluating all our results, but this is our experience. And as you can see, we performed more than 281 patients, and we have one death in the newborn with 2 kilos of weight after 8 days old. The age is from 20, mean 21, from 1 month to 59 years, and the pediatric patients are 136. The Ross Connors has been performed in 27 patients. This is our total experience. And we presented in Annals of Thoracic Surgery in 2008, we presented the adults' results. In this case, we saw that after 10 years, 7 years, we started to have autograft valve regurgitations, and also after autograft root dilation start to be present after 5 years after operation. So you have to know that in the adults population, after 5 years, 10% start to have a dilation, and in 10 years, you have to do a replacement of our aortic root. For that reason now, we decided to evaluate the pediatric population. The pediatric population is 136 patients. As you can see here, there are infants, 8, preschool child, 16, children from 6 to 12, 48, and adolescents, 64. These results are very, very important, because these results showed us what we have to do nowadays and which are the results after almost 20 years. Here are the technical details of the Ross operation. We did 121 root replacement. because especially in small children, it's impossible to do inclusion or subcoronary technique because the aorta is small, the pulmonary artery cannot go inside the aorta. So the majority of the techniques are root replacement. Subcoronary replacement in 10 and 5 inclusion technique in 16, 17 years old patients. Okay, our results, as I told you, the hospital mortality was 0.7, one patient, 2 kilos newborn after balloon valvuloplasty. The results were aortic insufficiency, and the baby was underwent to Ross operation with a good surgical result, but he died 10 days later on for infection diseases and low cardiac output. Late mortality, 2 patients, and also this allowed us to understand that some of these patients could not be operated. The Milan follow-up, as you can see, is almost 100 months, range from 12 to 235. The reoperation, 6 patients had aortic valve replacement, 4 patients ventral operation. The melody has been done in 6 patients and 1 patient at homograft replacement 88 months after melody implantation. And these are the results after more 15 years. And as you can see, there are freedom from neo-aortic reintervention was 96% at 5 years, 80% after 10 years, and the freedom from moderate neo-aortic insufficiency, 86% at 5 years, and 63% after 10 years. But this is all pediatric population. For that reason, we decided to go inside the pediatric population, and we evaluated the results below 12 years and above over 12 years. So below 63 patients below 12 years has been operated, and the hospital mortality is 1 patient, always the same. Later mortality, 2 patients, mean follow-up 96 months. We reoperated 2 patients, 1 for aortic replacement and the other with homograft replacement. The other has not been operated at the melody implantation. Okay, these are the 2 cases of who died. One because infarction, huge infarction, 2 years after operation due. If we can open, no, we have to wait. Don't worry. Che puelle. Ma. Okay, as you can see, the LAD is completely closed. It was completely closed. He had infarction. We performed an operation with a mammary artery bypass graft on LAD, and but after 1 year, the heart presented low cardiac output, and the child died. The second one was the Williams syndrome. And after 5 years, he presented the chronic myocardial ischemia with intimal hyperplasia. As you can see here, typical for Williams syndrome. The hyperplasia closed the LAD, left the descending anterior. For that reason, Williams syndrome is a contraindication to Ross operation. And we learned also that. Well, when you give a look to the results, we are very surprised, but we have a very nice, a very good indication for the future. For example, these are the patients below 12 years of age, and we have free of homograft reoperation at 10 years, 90% of the patients. And below 12 years, we have, after 15 years, 80% without freedom from moderate aortic valve regurgitation, better than the results in adults. If you will give a look at the population over 12 years of age, 73 patients, no mortality, no late mortality, mean follow-up, 98 months. Aortic valve replacement has been done in 5 patients, and ventral operation in 4 patients, homograph valvuloplasty in 1 patient, 2 melodies. Okay, these are the list of all the pediatric patients who needed a reoperation. As you can see, only 2 patients were below 12 years of age. So, when we compare the 2 populations below 12 years and above 12 years, you can see that freedom from homograft reoperation are much higher over above 12 years of age, because we have to put the homograft, small homograft, in small child, 3, 2, 4, 5 years. And this homograft needed to be changed because the baby or the child grow. For that reason, the results are in homograft better below over 12 years. But regarding the autograft, look, there are very huge differences in between below 12 years. The freedom from moderate aortic valve regurgitation at 15 years is over more than 80%. Not the same over 12 years, because after 15 years, the freedom from moderate aortic valve regurgitation is only 56%. And if we compare the 2 populations, for autograft reoperation, in the patient below 12 years, we have 2.8% of patients after 98 months of follow-up, and 13% over 12 years. So these data are very important. These data allowed us to understand and to know that the Ross operation is the best operation in children below 12 years of age. And since many years, we don't do Ross operation in adults, because our young boy, 20, 22, unless special condition, I don't suggest you to do the Ross operation in young population, but is mandatory, and the results are very fantastic below 12 years of age. So the absolute contraindication are pulmonary valve disease pathology, congenitally absent or deformed pulmonary valve, obviously. No genetic defects like Marfan, Ehlers-Danlos, and now we know also Williams syndrome. As you see, a significant immune complex disease as a coexisting disease, especially if the etiology of the aortic valve disease, systemic lupus, ankylosing spondylitis, and Reiter disease. These are absolute contraindication to Ross operation. Relative contraindication, dysplastic dilatic aortic root, rheumatic aortic regurgitation, concomitant mitral regurgitation. It depends by the center. Aortic regurgitation, the annulus dilation seems not to be a contraindication, it's relative. Bicuspid aortic pulmonary valve can be a relative contraindication, and associated cardiac lesions depends by the experience of the sample. So, in conclusions, the Ross procedure seems to be the best therapeutical option for aortic disease in pediatric population, especially below 12 years of age. For the other patients over 12 years, the indication for Ross should be given for selected cases, but you have to know that the long-term results can oblige you to redo the operation to change the valve many times. Thank you very much for your kind attention.
Thank you very much, Professor Frigiola, for these outstanding results and big experience. It's not so many surgeons in the world with such experience like you have. Now, a paper is open for discussion, and please, Professor Diak.
Professor Frigiola, I enjoyed very much your presentation, as always. One question, why did you choose this landmark 12 years? What are the reasons?
Well, the reason was occasional consideration that normally the pediatric patient is considered up to 12, 13 years of age. And we decided we go towards a very true pediatric population. And when we saw the results, there was a completely difference in the results above, over 12 years and below 12 years. We didn't know exactly why. And we are looking for this in order to, for the reasons for that. We suppose that elasticity of the aortic, the valve, is better in small children. So the results can be much better. But we don't have the real explanation for that. And we are trying to discover that with other investigations.
So it's a statistical observation, more or less?
Absolutely. But
Okay.
It's important to know because you have to, if you have to take the decision nowadays, if I have 17 years old, I know that the possibility to redo the operation are much, much higher than if I do at 8 or 10 years of age. So maybe I put a mechanical valve. So I think that our results show that give a very good indication for selection of the patients.
And the second question is, I'm very pleased that you started to look more deeply into the pathology of the collagen, generally speaking. And connected to that, are you doing a kind of screening for this pathology of collagen in the pediatric population?
But usually, yes. I mean that all the patients are evaluated before the operation, and if there is also one of the investigations that we do is a chromosomal and a chromosomic examination, and all anamnestic factor correlated with the family, with some connective disease or something like that, and we go on with the investigation. If we discover something, we eliminate it. One observation, obviously, when we do the Ross operation, is because we tried to do first aortic valve repair. We don't do a Ross operation if we can repair the valve. Because someone can say, why did you try to repair the valve? Sure, we tried, but in children, especially with bicuspid valve, they performed valvuloplasty in the newborn age or at age or several other at the age of 2 or 3 years. Very often the valve is completely destroyed. In any case, first we open, we check the valve. If it's not suitable for us, according with our experience, for good repair, we do a Ross operation.
And the last quick question. Did you identify in adult group any risk factor you can avoid to prevent aortic regurgitation and dilatation of the autograft?
No, the risk, I think, is even if some literature doesn't present that, is a bicuspid aortic valve. And so if we start with a dilation, with a not normal root, but also the root is quite small dilation, we we be careful and maybe we don't do ROS. You're welcome.
And one last question. We all know that one of the main concerns is the autograft dilatation in ROS operation. And I had the honor to help you exactly in the period you used the wrapping technique with Gore-Tex. So you stopped doing this. Do you think it's important to do a procedure to prevent this dilatation, or do you think it's not necessary?
No, I think it's very important. Why I choose a Gore-Tex membrane? Because it's elastic one. One of the problem, there are different techniques like a Dacron tube. They put a Dacron tube, but Dacron tube is rigid. We already demonstrate in the Tyrone David operation, if you put a rigid conduit, you can damage the cusp. So if in the ROS I put the Dacron tube, I can have the rigidity of the sinus of Valsalva with deterioration of the cusp, which is not the case of a Gore-Tex membrane, because it's a membrane, it's like pericardial. So this membrane doesn't allow the dilation, but it's still elastic. So it allowed the cusps, the sinus of Valsalva to be normal. We did that, and we presented to major journal for publication, and they told us 5 years ago, your follow-up is too short. For that reason, we are waiting 10 years. And this year, we are almost 10 years. So now we started to review all these 20 patients, but because we follow all the patients, I know there is no dilation in all these 20 patients after 10 years. So it should be very important results when we start to publish that.
So you are planning to restart this technique?
Yes, sure, in the big one, because I cannot do in small children because they have to grow. If I put the membrane, they never grow, and they have aortic stenosis, supravalvular one. Okay.
Thank you very much.
Professor Gaspar, please.
Thank you, Professor Frigiola, for sharing with us your outstanding experience. We are very glad. I have some questions regarding the ROS procedure for small children. Did you use some other materials to reconstruct the right outflow tract, or only homograft? And from where did you have? From bank in Italy, or you preparing the hospital?
Okay, good question. This is my experience, or our experience in San Donato, but I performed more than 50 ROS around the world. And the problem was, I haven't homographed in the majority of these countries. So I was obliged to use Contegra or other xenograft, but the results are not the same than also Elkins demonstrated. The homograft is the best conduit for the ROS operation because the pulmonary pressure and the right ventricular pressure are low. So the long-term results, the duration of homograft is almost at 20 years, 80% is still freedom from reoperation. The other conduits I don't like, but sometimes it happened that we don't have homograft. In Italy, it doesn't happen because we have several bank tissues, and they have a lot of homograft. Pulmonary homograft for ROS is better than aortic homograft. So we don't have a problem in Italy. I had a problem in other countries, and if you have nothing else, you have to use Contegra, but the short-term results are not so good.
And for the children over 12 years of age, if you are not able to repair aortic valve, and it's not possible to implant a mechanical one, even biological, did you still suggest to use a homograft in place of ROS? It's an option to jump over some years, still
Okay.
the annulus is growing.
Yes, I'm not in favor for many reasons. The homograft in a young patient below 18 years has a very, very short duration. the homograph will be destroyed in 3-4 years. So at that point, it's better to put a mechanical valve. For example, is an extreme case. I performed a ROS in 1 or 2 years patient of age, and they had 4 of them had homographed in other institutions. After 6 months, they had severe aortic regurgitation, and in 3 cases, we didn't find the aortic cusp completely destroyed. So younger is the baby, shorter is the long-term, the duration of the homograph. Also, in a 17 or 16 years of age, old patient, because the duration can be 5-7 years, but normally after 3-4 years, the homograph is destroyed. For that reason, I don't like to do homograph. I prefer mechanical valve.
Yeah, we have very short experience. We started in '97 in Timișoara Center with Professor Laufer with homograph and some ROS, and we did only 15 cases till now, and we reoperate 3 of them adult. Also, we did for 3 teenager, 15, 16, 17 years of age, which are still in good condition after 5 years. Thank you very much.
Okay, you're welcome.
Thank you very much, Professor Frigiola, for your beautiful lecture and huge experience you shared with us. Thank you very much.